Welcome back, everyone, to Uncovering Bailey in Love with Snazzy Surgeon. And today, uh, we see this all the time in clinic, right? Nipple discharge.
Yeah.
And it's one of those things that I think can really worry patients. And for us, it's like, how do we apply, our surgical experience to know what's just normal and what could be a sign of something a little bit more worrisome?
Absolutely. I think, it's something that we see day in and day out in our practice, and really being able to kind of have that risk stratification based on what the discharge looks like immediately
Right.
is really, I think, the key.
Yeah, so let's start off with some reassurance, right? Because, we look at Bailey and Love and thankfully what we see in our practices too is most nipple discharge is benign.
Yeah.
And a lot of it is just kind of those ANDI changes, those aberrations of normal development and evolution.
Absolutely. And I think, the first question that I always ask myself when I see a patient with nipple discharge is it coming from a single duct, or is it multiductal? And then is it unilateral or is it bilateral? And I think just those two simple kind of questions and exam findings can be so helpful in guiding you.
Totally, totally. And then obviously we're always on the lookout for those things that make us think, this could be something a little bit more concerning. And I think we all kind of have that checklist in our mind of, the four S's.
Right.
What are those four S's that really make us think, okay, we need to do a full workup on this patient?
So the four S's are single duct spontaneous, and then either sicarious or sanguineous, so a clear or bloody discharge.
Yeah.
And, when you have those, particularly that single duct and then either a clear or bloody discharge,
Right.
you really need to go through that triple assessment to make sure that there's nothing else going on.
Absolutely.
Right.
Yeah, that spontaneous single duct discharge,
Right.
especially if it's clear or blood tinged, that's kind of the red flag for us to really do a deep dive.
Yeah.
So on the flip side of that, thankfully, a lot of times it's not something that's going to land someone in the operating room.
Yeah.
So what do we tell our patients about, kind of normal physiologic nipple discharge?
So typically when you see a discharge that is multiductal and multicolored, that's going to be benign. And really the treatment for that is patient education and reassurance,
Right.
making sure that they understand what's going on and making sure that they're comfortable with it.
And what about those patients that have a nipple discharge and they happen to be pregnant? What do we do about those?
Yeah, so we know that with pregnancy, there's increased vascularity in the breast tissue, and that can lead to a serous or even a bloody nipple discharge, and it can be quite alarming for patients. I think our practice has always been to recommend an ultrasound just to make sure that there's nothing else going on.
Right.
While in most cases, this resolves after the patient delivers.
Yeah, I think that's totally fair.
Yeah.
Better safe than sorry. So, kind of going along those lines of, those things that are concerning, let's kind of break it down by discharge type.
Okay.
So if we have a patient that comes in and they have a single ductlet clear or serious discharge, what are some of the things that could be going on there?
So in our practice, the number one thing that we see when we have a single duct clear or serious discharge that's persistent is an intraductal papilloma. And we know that most of those are benign, but it's one of those things that it can be hard to figure out on exam alone.
Right.
And there is that small potential for malignancy or an association with DCIS, so it's something that we need to keep on our differential.
Yeah.
And then you can also see things like ductal hyperplasia, ductectasia, and even ductal carcinoma.
Okay. And now let's go to the one that I think really, worries patients the most and probably worries us the most, and that's a bloodstained discharge. So how do we approach a patient that comes in with a bloodstained discharge?
Yeah, so if you have a bloodstained discharge and it's coming from a single duct, you really have to have a high suspicion for either an intraductal papilloma or even an intraductal carcinoma.
Okay.
You can also see ductectasia
Right.
present with a bloody discharge from a single duct as well. Now, if it's coming from multiple ducts, you can see things like carcinoma and ductectasia. But really, that single duct is what kind of tips you off that, okay, this could be something a little bit more serious.
Interesting. And what about those patients that, sometimes you'll see this like a black or green or even a muddy looking discharge? What do we think about when we see that?
Yeah, so those are typically associated with ductectasia.
Okay.
That's from the kind of inspissated secretions within the dilated ducts.
Makes sense.
So, most of the time that is a benign process,
Right.
but you have to make sure that you're differentiating it from other things clinically.
Absolutely.
And sometimes imaging can be helpful in that.
And then what about purulent discharge? What does that make us think of?
So purulent discharge, typically that's going to make you think of periductal mastitis
Yeah.
or a breast abscess.
And then we got to think about, milky discharge, galactorrhea,
Yeah.
In that lactating, non-pregnant patient.
Right.
That could be a little bit of a diagnostic challenge sometimes.
It can be. So, if you have a spontaneous milky discharge from multiple ducts and it's not related to recent childbirth or breastfeeding,
Yeah.
you have to think about what's going on hormonally.
Right.
So the most common thing is going to be a prolactinoma.
Right.
That's a pituitary adenoma that leads to that hyperprolactinemia. But you also have to think about drug-induced causes. So there's a number of medications that can lead to an elevated prolactin level.
Oh, wow.
So you have to think about things like antipsychotics, like haloperidol and chlorpromazine, some antidepressants like amitriptyline, antiemetics like metoclopramide, and even H2 receptor antagonists like cimetidine.
Wow, I had no idea about those medications. Okay, so that's a great point. Really good to get a good medication history in your patient.
Absolutely. Yeah, a good medication history and then an endocrine evaluation is important in those cases.
Now, what about when we see something coming from the nipple and it doesn't seem like it's coming from a duct? Like, what if it's coming from the actual nipple surface?
So if you see something coming from the nipple surface and it's not from a distinct duct orifice, that should make you think of Paget's disease of the nipple.
Okay.
And, that's associated with an underlying DCIS or invasive carcinoma.
Right.
You also have to consider benign things like eczema and psoriasis that can sometimes affect the nipple areolar complex. And then also infectious etiologies like a chancre.
Wow. Okay, so that's, really emphasizing the importance of a good history and physical exam.
For sure, yeah.
So now let's talk about, when we do find something concerning, when we have those 4 S's that we talked about before, we need to work these patients up. So what is our approach to that triple assessment? And what do we typically do for each component?
Yeah, so that triple assessment is going to be that clinical exam, the imaging, and then a biopsy. And that's the cornerstone of our evaluation when we think that there's a chance for malignancy based on that nipple discharge. So for the clinical exam, obviously we're going to do a thorough palpation of the breasts looking for any masses or other abnormalities. And then we're also going to palpate the regional lymph nodes.
Right.
And then for the imaging, ultrasound is the most common imaging modality that we use.
Got it.
And it's really good for visualizing the subareolar region and then also detecting intraductal papillomas. So it's been shown to have a diagnostic accuracy of about 85% for intraductal papillomas.
Wow, that's pretty good.
Yeah, and it can also help us identify dilated ducts,
Okay.
which might kind of clue us in that there's something else going on within the duct.
Yeah, absolutely. And now, I remember in training, we used to hear about ductoscopy and ductography.
Yeah.
What's the role of those in our current practice?
So ductoscopy is technically feasible,
Okay.
but it's not used routinely in clinical practice,
Right.
mainly because it is invasive and there is a learning curve to it.
Makes sense.
Ductography is even less useful these days.
Okay.
The diagnostic yield is not great.
Got it.
And it's pretty uncomfortable for the patient, so we just don't do it very often.
Yeah, that makes sense. And what about, sending nipple discharge fluid for cytology? Is that something that we're still doing routinely?
So cytology has been shown to have a really low sensitivity and specificity for detecting malignancy in nipple discharge fluid.
Interesting. Okay.
So a lot of breast clinics have stopped doing it routinely.
Got it.
We really focus on high-quality imaging and then image-guided or surgically excised tissue to get our diagnosis.
Okay, so now let's talk about how we manage these patients. So let's start with that non-bloody discharge that we think is physiologic.
Okay.
How do we manage those patients?
So if it's non-bloody and we think it's physiologic based on our exam and imaging,
Yeah.
then really all we need to do is reassure the patient and observe.
Got it.
Sometimes we have patients with really persistent, profuse, non-bloody discharge, and they get really worried about, staining their clothes or social embarrassment.
Yeah.
So in those cases, we can consider surgical intervention. And there's 2 things that we can do. There's a microdochectomy,
Okay.
where we just take out a small portion of the affected major milk duct near the nipple.
All right.
Usually that's about 1.5 to 2 centimeters.
Okay.
And then if it's a little more widespread and involving multiple ducts,
Right.
then we might do a major duct excision.
Got it. Okay. Now, what about when we have that bloody or serous discharge? We talk about how that has a higher potential for malignancy. So how do we approach those patients?
Yeah, so you're right. The risk of malignancy with a bloody or serious discharge is going to depend on the patient's age.
Okay.
So for patients under 40,
Yeah.
if they have a normal triple assessment, even if they have a bloody discharge, we typically reassure them and then follow them annually with clinical breast exams and imaging.
Okay.
But if the patient's over 40 and they have a single duct bloody or serious discharge, then we usually recommend a microdochectomy.
Got it.
And that lets us both kind of investigate what's going on because
Yeah.
we get that histology and it also removes that involved duct.
Okay. Makes sense. And then what about if it's involving multiple ducts?
So if it's involving multiple ducts in that older age group, then we would do a Hadfield's major mammary duct excision.
Okay.
And typically we'll take out about 5 centimeters of the major milk ducts
Got it.
as they kind of come together towards the nipple.
Makes sense. Yeah.
And that's because, most of those intraductal papillomas and early carcinomas are going to be in that proximal ductal system.
Okay, so basically, just to kind of summarize everything that we talked about today, nipple discharge, it's a pretty common presentation.
It is.
And it can range from, completely benign and physiologic to, something that's a little bit more worrisome.
Right.
But I think the key is really having that systematic approach.
Absolutely.
And really incorporating those characteristics of the discharge with a good thorough triple assessment to really guide our management.
Yeah, and being able to differentiate between those physiologic and pathologic discharges. Absolutely, by using those 4 S's and making sure we do a complete workup.
And always thinking about that patient's age, too.
Absolutely.
Especially when it comes to, the bloody or serious discharge.
Right.
And knowing that we've got those surgical options from that targeted microdochectomy for that single duct all the way to that more extensive major duct excision.
You're right.
When it's multiductal.
Yeah, exactly.
Well, this was a fantastic discussion. Really appreciate your expertise.
My pleasure.
And thank you all for listening to our podcast. We'll see you next time.
See ya.
Bye.